So now today we are going to see hyperglycemic emergencies. So diabetic ketoacidosis and hyperosmolar state. अब ये diabetic ketoacidosis, it has a persistent name. When I was in medical college, it used to be called DKA or diabetic ketoacidosis. The other condition, the hyperosmolar state, has changed many names. It was called HONC, hyperosmolar coma, and now it's called hyperosmolar state, hyperglycemic hyperosmolar state. Now look at this case vignette. 38-year-old diabetic was brought to emergency room. He was confused and febrile. Now what would you do? What will be your first line of action? What would you immediately do? So you're going to check the blood glucose level. Suppose if you don't have the facility of blood glucose testing immediately, your glucometer is misplaced, then what? Yes? What is that breath test? So where you can smell that, he's saying that you smell for presence of ketones. That's what you're suggesting? How can you smell that ketones in the breath? You see, in an open atmosphere of the emergency room, it's not possible. It's very difficult. So that was the classical teaching when the patients would be lying in a cubicle, in a small cubicle that is closed, and they are breathing, and you enter in the room, you find that sweetie smell of ketones. But it's not possible. So what would be your immediate line of action? He's a diabetic. He's confused. What would you do? Suppose we don't have the glucometer. The first action would be you check the blood sugar. But suppose in the busy emergency you have not been able to locate it. Would you waste your time in locating that glucometer or do something else? You immediately give this patient concentrated glucose. Giving a few mLs of concentrated glucose is not as dangerous as delaying the treatment of hypoglycemia. Sometimes it may be possible to pick clinically that this is hypoglycemia and not the hyperosmolar state, or vice versa, because hyperosmolar state is associated with dehydration. Hypoglycemic patient may not be dehydrated, but don't risk that. Immediately give glucose. That's going to cause no harm. But delaying the treatment of hypoglycemia may be detrimental for the patient, because glucose is required for the functioning of the cortical neurons that are the more sensitive neurons. They will start dying. So treat hypoglycemia immediately, and if it turns out to be hyperglycemia, it's no harm done. So immediately, if you get a diabetic and you find that the patient is confused and you're not able to do a blood sugar, or don't delay the treatment of hypoglycemia. So you will give glucose. Now, what is dysglycemia? Dysglycemia is abnormal blood sugar. It can be hypoglycemia, it can be hyperglycemia. Hyperglycemia can be hyperosmolar state, or it can be diabetic ketoacidosis. So you got hyperosmolar state and diabetic ketoacidosis. These are two emergencies which are similar. There are few differences which may at times be critical, but these are fairly similar clinical situations. So what is the reason for hyperglycemia? Is insulin deficiency. Now, insulin deficiency can be of what types? How many types of insulin deficiency may be there? There may be relative insulin deficiency, there may be absolute insulin deficiency. Absolute indeficiency means that insulin is not being produced at all. Relative deficiency is whatever amount of insulin is being produced is not enough to maintain glycemia or the metabolic normalcy. So in which condition you have relative insulin deficiency? So hyperosmolar hyperglycemic state. In DKA, the insulin is very, very low, or it may be absent even. So there is hyperglycemia resulting in profound osmotic diuresis. When there is high osmolality of the blood, there is osmotic diuresis. There is severe dehydration. There may be mild metabolic acidosis because of the sluggish circulation, but usually metabolic acidosis is not a problem in hyperosmolar state until and unless a precipitating cause can induce metabolic acidosis. For example, severe overwhelming sepsis can induce metabolic acidosis. Otherwise, it's not a problem. When there is absolute deficiency, again there is hyperglycemia, there is osmotic diuresis, and metabolism is shifted to fatty acid utilization because very small amount of insulin is required to prevent fatty acid metabolism from starting. So in hyperglycemic, hyperosmolar state, we do not have fatty acid metabolism. So the consequence of fatty acid metabolism will be production of ketone bodies. So there is severe dehydration, profound anion gap metabolic acidosis secondary to ketone body formation. So in this condition, we have metabolic acidosis, which is quite profound in some cases. So in hyperosmolar state, we do not have metabolic acidosis. Now the patients are dehydrated. How can you differentiate that this patient has metabolic acidosis, this patient does not have it? What happens when you have got metabolic acidosis? So respiration is stimulated as a compensatory mechanism to blow off carbon dioxide to maintain pH neutrality. So there will be hyperventilation. Now the clinicals, there is severe dehydration with altered mentation. Feature common to both conditions, there is increased thirst, increased urination, increased hunger, weight loss, blurred vision, headaches, weakness and postural hypotension, altered mentation. So these are pretty similar in both conditions. They're not really very different. So judging on the basis of this to define this is DKA or this is hyperosmolar state is practically very, very difficult. I don't think we can differentiate on this. The differentiating feature is DKA has dehydration, there is co-small breathing. Now, what are the labs? What labs would you like to do? So first thing, you will check blood sugar. You do serial blood sugars. When your number 1 blood sugar is needed for diagnosis, number 2 blood sugar is needed for monitoring the treatment. We'll see how we monitor the treatment. The blood sugar is required for monitoring the treatment. You go for electrolytes and osmolarity. Osmolarity we do not do very frequently, but the electrolytes we check very frequently. Which electrolyte is the most important? Potassium. So you have to keep an eye on potassium. There is some phosphate loss as well. When there is DKA, I presume you have studied the pathophysiology of DKA. When there is hyperosmolar state, there is hyperosmolar diuresis, osmotic diuresis. What will happen? Body retains sodium, potassium is lost. So there is a lot of potassium wasting, and with this phosphate is also wasted in some patients, but this is clinically not very important. So generally we do not require the monitoring of phosphate and replacement of phosphate. In very few patients, when there is an atypical features, you can go for the replacement of the phosphates, otherwise they're generally not required. You go for blood gases, the ketone bodies in the blood or urine. You need renal functions testing because if the patient is in kidney failure or heart failure, giving fluid liberally may be a problem. So you need to have baseline testing. Patients who are more than 40 years, ECG should also be done. Evaluate for precipitating cause. What are the precipitating causes of decay? Which precipitate decay or even hyperosmolar state? What is the most common reason that patients go into these states? Yes? Omitting the dose of insulin. Omitting the dose of insulin is the most common reason. DKA can be one presentation of type 1 diabetes mellitus as well. And then you got sepsis. And then you got any systemic stress like myocardial infarction, stroke, even severe psychological stress can precipitate decay in some patients. Go for CBC, urine routine examination. If the cultures are required, go for chest X-ray and an EKG. So these are the routine investigations which you require. Now, what are the differentials of our patient who presented to us? One can be, we said, hypoglycemia. The patient was febrile and confused. Meningoencephalitis is another differential diagnosis. We are considering hyperosmolar state, but the patient can have meningoencephalitis. You cannot say that this patient is not having CNS infection. It may be strokes, organ failures, drugs, and heat stroke or thermal related consciousness changes. So you can have these as your differentials. But once you do a blood sugar, you really find that this is hyperosmolar state, and the differential comes to your mind is decay or hyperosmolar state. And if the patient is febrile, always consider in confusion that this is meningoencephalitis, rule out meningoencephalitis. Now we are consistently saying that patients with this situation, they present with hyperglycemic state. Can you have a euglycemic decay, or have you heard this term? Euglycemic decay. If it is less than 250, we call it euglycemic decay. And what conditions will you be seeing euglycemic decay? Suppose if the patient has reached the emergency, has taken shot of insulin before coming to the emergency, the blood sugar may drop. And a class of drugs you called SGLT2 inhibitors. Have you heard the name? Sodium glucose cotransporter 2 inhibitors, SGLT2. If the patient is on SGLT2 along with insulin, it is possible that the blood sugar may not be high, even the patient still may be in DKA. So this is euglycemic diabetic ketoacidosis. So keep in mind that if you've got metabolic abnormality, if you feel that patient has metabolic acidosis, always go for ketones. Never miss it. Now, what is the management plan of patients who present with hyperglycemic emergencies? What will be the first thing you do? You go for the standard care of comatose patient. What is the standard care of comatose patient? Prevent aspiration. Take measures to prevent aspiration, even if you have to put in endotracheal intubation. So you go for the prevention of aspiration, bladder and bowel care, skin care, and keep the patient safe from injuries. So this is the usual patients for patients who are comatose. And then you go for fluid and electrolytes. Replace insulin, antibiotics and anticoagulants if indicated, correction of acidosis if required. So this is our main treatment plan. Now the one on the right side or left side of your screen is not required in patients who got hyperosmolar state. Generally, they are not in metabolic acidosis. But patients who are in DKA, they can be in metabolic acidosis, and sometimes we may need to correct metabolic acidosis. Treatment of the precipitating cause, so treat the infection, treat the whatever is the underlying cause, for example, myocardial infarction. So treat it as per indications of that precipitating cause. Now fluids. How much fluids to be given? This depends upon your estimation. How much is the fluid loss? What is the general fluid loss in a patient who's got frank DKA? It's about 6 liters, 5-6 liters, and in patients who are in hyperosmolar, hyperglycemic state, they may have a loss of 6 to 9 liters. So you assess the volume status. If there is mild hypovolemia, evaluate corrected serum sodium. What is this corrected serum sodium? Why we have not written simply do a serum sodium and that's it? Why we correct it? Patients who have got hyperosmolarity, those who have got hyperglycemia or hypertriglyceridemia, the sodium assay method may be interfered. The glucose or triglyceride, they interfere with the measurement of sodium. So sodium may be spuriously low. It may be wrongly low. So you have to get the corrected sodium. And there are few new methods of testing serum sodium, which are electrode based. They just circumvent this error. So evaluate for the corrected sodium. If it is high or normal, give 0.45% normal saline, 200 250 milliliter per hour. That is half normal saline. If the sodium is normal or it is high, give half normal saline. And if the sodium is low, give 0.9% sodium chloride, 200 to 250 milliliters per hour. So this is what you do if the dehydration is or the volume loss is not really very high, it's mild. At blood sugar 200, switch to 5% dextrose water. Since at the same time you are giving insulin, keep in mind the management of, again, this hyperosmolar state is not an individual's business, it should be a teamwork. So if the blood sugar is dropping, if it is come to 200, switch to dextrose water. If the patient has severe hypovolemia, rush saline 1 to 1.5 liters in first hour, and then subsequently based on your clinical assessment. So generally what we do is we rush almost 1 liter in first half an hour, and then we slow down so that we do it 1.5 liters in 1 to 1.5 hour. If you're considering patients who got hyperosmolar state, the fluid loss can be more than this. In those patients, you may give, this is about 20 to 30 milliliters per kg per hour, this 1 to 1.5 liters. And in patients who got hyperosmolar state, you can give more fluid up to 50 milliliters per kg per hour. If the patient has shock, so this is not cardiogenic, it's cardiogenic. If the patient has MI, patient requires strict monitoring and pressor support. So this is how you give fluid, and in these patients it's better if you put in a central line and manage fluid according to the central venous pressure. Electrolytes, it is very important. Keep in mind, potassium is a big problem in patients who got diabetic ketoacidosis. So you have to test potassium immediately before you start doing anything. So you take the samples and send for analysis and request an urgent report on potassium. Before start treating for potassium, establish adequate renal function. This is by urine output of 50 milliliters per hour. Now, how can you know when the patient has landed with you, the urine output is 50 milliliter per hour, because you are going to know it after 1 hour at least. Is it possible to have urine output measured before that? You can roughly estimate if it is, you check it in 15 minutes, multiplied with 4. So you can have a rough assessment. Otherwise, it's not possible. But you have, see, patient is having adequate urinary flow. You check the serum potassium. If it is less than 3.3 milliequivalents, what will you do if this is 3.3 milliequivalents per liter? Because below this, it will start causing trouble. Hypokalemia may result in hyperglycemia. Similarly, hyperkalemia can result in problems. So what will you do now? You will not give insulin. You'll hold insulin, because insulin is going to cause intracellular shifting of potassium. It will exacerbate hypokalemia. If the potassium is less than 3.3 milliequivalents, do not give insulin. In fact, give potassium 20 to 40 milliequivalents per hour until potassium is more than 3.3 milliequivalents per liter. So you see, if it is less than 3.3, do not give insulin. If it is between 3.3 and 5.3, 20 to 30 milliequivalents of potassium in each liter of IV fluid to keep potassium between 4 and 5 milliequivalents. So that means you have to frequently check potassium. So the potassium is, until it is stabilized, it is measured every hour. So is the blood sugar. If potassium is more than 5.3, what will you do then? You will give insulin. What else will you do? Generally, this does not happen until the patient is in renal your patient is taking some potassium sparing drugs. Otherwise, it doesn't usually happen. So what will you do now? If this was hypokalemia, you withheld insulin. And if this is going towards hyperkalemia, what will you do? Do not give any potassium. So monitor every 2 hours and see the potassium remains between the safe zone of 4 to 5. Now the insulin, in patients who got hyperglycemic states, always use regular insulin. Patients who got profound deficiency, they should give intravenous insulin. Patients who got mild disease, they can be given subcutaneous insulin. So patients who require intravenous insulin, 0.1 unit per kg bolus is given IV. So 0.1 unit per kg for 70 kg patient, you give 7 units intravenously. So this should not be given subcutaneously. Why in these patients it should not be given subcutaneously? You can have an option of giving subcutaneous insulin. Why should it not be given? Because there will be poor absorption. Patient dehydrated, there will be no absorption because there is no flow into the skin. And as you hydrate the patient, the volume expand, there will be sudden absorption of insulin from that site. So this will result in hypoglycemia. So you do not want that. So give intravenous insulin. Intramuscular insulin can be one option, but generally it is intravenous insulin that's the best option. And then you continue with 0.1 unit per kg per hour continuous infusion. So this is about on average 6 to 7 units per kg of continuous infusion of regular insulin. When the patient has uncomplicated DKA, there is not much of the problem. Patient has presented earlier, you can use the subcutaneous route. So you can use this rapid acting insulin 0.3 units per kg, then 0.2 units per kg 1 hour later, and then 0.2 units every 2 hours. So it's the situation when there is mild DKA, there are no complications present, you can think of a subcutaneous route. But I have not seen such patients. They come very infrequently. Most of the patients who reach you, they are usually in advanced DKA, they are dehydrated. So there you need to give intravenous insulin. If blood sugar does not drop by 50 to 70 milligrams per deciliter in first hour, double IV or subcutaneous insulin bolus. Repeat a bolus or double it. So if it is not falling at this rate, 50 to 70 milligrams per deciliter, so you give another bolus and you keep on monitoring. If the blood sugar drops to 200 milligram per deciliter, reduce insulin to 0.02 to 0.05 units per kg per hour infusion. Keep blood sugar between 150 to 200 until DKA is resolved. Now, why do we want to keep the blood sugar in this range? We do not want to bring it to normal. Why? We say we replace it with dextrose so that blood sugar does not drop. What will happen if the blood sugar drops precipitously? The blood will become thin. CSF will become more thick. You understand me? The blood sugar drops too quickly. The blood will become more thin. And the CSF becomes thick, the blood becomes thin, fluid moves from the blood into the CSF, resulting in increase in intracerebral pressure that we do never want because that has very serious consequences. So we change the fluid from saline to dextrose. Now what to do with metabolic acidosis? In hyperosmolar state, we do not have a problem with metabolic acidosis. In DKA, it may be a big problem. So if the pH is less than 6.9, we have to give bicarbonate. So what we do, 100 milliequivalents of dilute bicarbonate in 400 ml of distilled water of potassium over 2 hours. Repeat it 2 hourly until pH is stabilized more than 7. The drug which is available in the emergency tray is concentrated 7.5% or 8.4% sodium bicarbonate, which is very concentrated, which is used for resuscitation in patients who got cardiac arrest. 7 point or 8 point some percent is very high, very concentrated. What is the problem with this high concentrated bicarbonate? If you give to a patient, what will happen? pH will rise, then what will happen? Yes? What is the consequence of that? It may not be alkalosis, the pH may go from 6.9 to say may 7.2 or 7.3. What will happen? The oxygen hemoglobin dissociation curve will be shifted and oxygen will not be released at the tissue level, so the patient will have tissue hypoxia. So it's not the rapid correction which is required in the situation. That is required only when there is cardiac arrest. There is abundant of anaerobic metabolism in cardiac arrest. So there is very severe acidosis and you may require concentrated bicarbonate, not in DKA. So you require dilute bicarbonate. You give potassium along with it because bicarb also causes shifting of potassium into the cells. So you have to be very careful when you are giving this sodium bicarbonate. Do not give a thick concentrated bicarbonate. Give a thin diluted bicarbonate along with that potassium. And if pH is 6.9 or more, we generally do not require bicarbonate. Sodium chloride, if you hydrate the patient with sodium chloride, it itself corrects the pH in acceptable ranges. So in these patients, we may not require any bicarbonate. Now, complications of hyperglycemia, patient may have renal injury because of the hypovolemia. The patient may develop ATN. And patient may develop thrombosis due to hyperviscosity. Now, the complications of the treatment itself. Now, they were the complications of the hyperglycemia. Now you start treatment, that can cause problem. It can result in hypoglycemia if you overdose insulin. It can cause hypokalemia. It can cause fluid overload including brain edema. So heart failure may be precipitated, there may be brain edema. So these may be the complications of treatment. So it's not that treatment is without complications. So you have to be very, very careful. So DK is a state in which the patients, 95% of the patient, they recover. Even more than that, if you are very careful, mortality in DK is very low as compared to in the hyperglycemic hyperosmolar state. Now I see the prognosis. Overall mortality in DK is 2.2% and HHS it's 11%. Why the mortality is high in HHS? Why? You see DK only 2.2% versus 11%. Why there is high mortality in patients who've got hyperglycemic hyperosmolar state? What's the reason? Yes? Oh, not really good. Because HHS is usually seen in patients who are type 2 diabetics. So type 2 diabetics may have associated heart disease, kidney disease, while type 1 patients who develop DKA usually do not have this sort of complications. So larger number of patients with type 2 diabetes, they have or may have associated comorbidities like heart disease or kidney disease. While in type 1 diabetics, these complications may be less. They are younger patients. Type 2, they're generally older patients, although we are having an epidemiological shift. So they may have this mortality high because of this reason. The bad prognostic indicators are deep coma, hypothermia, and oliguria. These are bad prognostic indicators. So this is about hyperosmolar state and diabetic ketoacidosis.